Hello again, everybody. Today we're going to go through the GI system, and a little disclaimer, I am on call right now, so we're going to hope and cross your fingers that I don't get paged in the middle of this. So let's get into it. Okay, so basic anatomy. I really don't think we need to go through this in particular in great detail. Further on in the slides, we're going to talk about, okay, when you're percussing or you're palpating, really understanding what's underneath it. But if you need the refresher, here's the image. Make sure you kind of know what's all connected to what and where all it's located in the abdomen. Okay, so this is just another view so that you can see with the rib cage as well, kind of where everything sits. Okay, so liver is up pretty high underneath that diaphragm, and your stomach kind of gets squished in there too. And then behind these two, let's see, maybe did I figure out how to do it last time? And so then behind these two here, you have, as you can see on the right, you have the pancreas and the kidneys and then the bladder. And then, oh goodness, the uterus would be like right about there. Okay. Oh, and I had a lot of fun when I was supposed to be doing other things, playing with slide transitions. So yeah, obviously I was super productive today. So abdominal musculature. You guys are probably even more aware of this than I am. But just understand that for surgeries and such, there's another layer that has to be cut to get to these organs. And that's where the majority of the recovery comes from. Okay, so quadrants, these are just listed out, okay? We'll see it in a picture in a couple of slides, but this is just listed out for you. This isn't something for you to necessarily just sit down and memorize so that you could say a portion of the right kidney is in the right upper quadrant. It's more to say, okay, my patient's pain is here. What's even underneath there? What am I even concerned about? What's going on? And we'll talk about in a little bit also how the abdomen can be tricky too. And so then this is again, right lower quadrant, left lower quadrant, just, listed out there. Just so that you have a general idea, okay, what's underneath there, what could be causing those symptoms. Oh, that's fun. Okay, so here's we just talked about 4 quadrants. Really, when you're palpating, sometimes we think about it in 9 sections. I mean, the struggle with abdominal pain is it's very generalized. Like the nerve, and maybe James can remember the terms, but I can't. So the nerve findings, so say I like cut my arm right here. I have nerves that are specific enough to say that cut is right there, okay? But in your abdomen, I think it's maybe, is it the somatic? I don't know. Anyways, like the nerves aren't that specific. The innervation isn't specific enough to say, you know what, my pain is directly at my belly button and it really is right underneath there. It's too much of a visceral type innervation. And so you can have a lot of referred pain and such as well. But in general, you want to keep an eye on, okay, what's really underneath there? What could be the cause? How do we narrow down that differential and that list of possibilities? Ooh. Yeah, try not to get too distracted. So abdominal pain is like the key, is like one of the biggest UGG things you can see on your schedule. Abdominal pain and fatigue, because just the possibilities are pretty endless. Okay, so this is a time when it's super important that you do not narrow your thinking. It's not like, okay, my patient comes in with stomach pain, so it must be GI. It must be constipation. You've got to broaden that that out. It can be anywhere from ectopic pregnancy to pulmonary embolism to kidney stone, and actually have absolutely nothing to do with any of the abdominal organs, okay? So you really have to think about as many things as possible. Important to note, this is a little bit of a side note, is any woman of childbearing age is pregnant until proven otherwise, okay? Because you absolutely cannot miss that. So if somebody presents, any female, that's, you know, in their 20s or 30s, 40s, even early 50s, they are pregnant until you can prove that they're not. Partially because the risk if you miss something is too high, okay? So even if they're like, but I'm on birth control or whatever, we've still got to rule it out, okay? And so for you guys, and I apologize, I digress a little bit because I need to keep in mind that for a lot of this, you guys are going to be referring out to a provider. And so you need to remember to think about what do you guys specifically really care about? And honestly, in this setting, I want you guys to try to figure out, is this surgical or not? Is this an acute case, or can this wait to see the doc? So really think, is this a surgical abdomen, or is this, you know, just a sick abdomen? Okay. So when you're going through your history, you're asking about the pain. When did it start? How long has it been going on? Is it a sharp pain, a dull pain? Is it really bad? Is it just like kind of a dull ache? Does it radiate anywhere? Meaning like sometimes like pain in your gallbladder can actually radiate like up to your shoulder blade. So people are like, yeah, so my side kind of hurts, but so does my back. And so that can give you some clues also. And then associated symptoms, nausea, vomiting. One of the biggest things that I can take homes I can give you is, did the pain come first or did the vomiting come first? So I think all of us can remember a time when we had like a bad stomach bug and we were just like puking our guts out. And when you retch that much, obviously your stomach's going to hurt after a while because of that sharp, intense contraction. And so that's normal. Vomiting, then pain. But if pain comes first and then they vomit, that's more indicative of like an acute abdomen, like a surgical abdomen. Sometimes you'll hear me call it a hot abdomen too. It's all just kind of interchangeable. Once again, associated symptoms, diarrhea, constipation, fever, fatigue, painful urination. Remember that system above and system below with your review of systems. And really, when it comes to abdominal pain, I'm asking a pretty thorough review of systems because I don't want to miss anything. So I'll go into cardiac, lungs, GI, GU, musculoskeletal, all sorts of different options there. Once again, aggravators or relievers. What medications are they taking? Are they taking their medications on an empty stomach? Okay. Do people have an appetite? If it's very, very rare that somebody has a hot abdomen that still wants to, you know, eat a bunch. Okay. And then are there certain foods that they can't tolerate? That kind of thing too. Are there foods that make it worse? Are there foods that make it better? Bowel habits. When was the last time they had a bowel movement? What did it look like? That kind of thing. Oh, that transition was boring. Okay, exam. This is, remember back when I talked about how you had to auscultate first. Okay, this is when. And that's because as soon as you start pushing on somebody's stomach, you can actually make more bowel tones than were originally there. And the research is actually kind of out about, you know, do bowel tones, like, even if you hear them or if you don't hear them, like, it's a little bit wonky anyways. So that might be something you hear change in the future. The way that I was taught and what the current recommendations are, to listen to each quadrant for 5 minutes. And if at the end of 5 minutes you do not hear any tones, then you can say that they're absent. But I mean, ain't nobody got time for that. So obviously not. When you're listening to bowel tones, you call them either normal active, hypoactive, or hyperactive. The only way you really get to know, like, I think there might be a technical definition of how many bowel tones quantifies hypo or hyper. I mean, don't really worry about it. It's pretty subjective anyways. So percussion, generally the big ones you want to know is the liver and spleen. Okay, are they enlarged? Obviously, if your patient recently had, a sore throat, didn't really get checked, and then finds out their spleen's enlarged and nobody really caught it, then they go out and play soccer and then they rupture their spleen and it turns out they had mono the whole time, and then all of the sequelae from that. So that's one of the big things you're looking for. So widespread dullness, if you're just like percussing all the way across somebody's abdomen and it's just dull, 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 they're probably full of poop, figuratively and literally. Okay, so that's when you would get into recommending like some bowel meds and such. Your book goes through like a sequence, like an appropriate sequence to percuss your abdomen, and like maybe I'm just a slacker, but I don't do a sequence. I just go like in a circle, like I do liver, spleen first and then everywhere else, and just I feel like as long as you have like a pattern or something so you don't miss any spots, you're probably fine. Ooh, I like that one. It's kind of cathartic. So, like I said, percussion notes of the abdomen. What do these descriptions I find super funny. It just takes a lot of practice, okay? So I want you to find the most over-exaggerated possibility for this. So to think about dullness, I want you to percuss like on a bone, okay? Or like your liver is the great example because it should just be like a dull thunk, okay? And then to panic and hyperresonant versus resonance, it's just different tones, okay? And the more you do it, the better you'll get at it. So palpation levels, so light palpation, if this is like the person's abdomen, I'm maybe going just like that. I tend to kind of palpate in a circle with multiple fingers, but then when it comes to deeper palpation, they taught me that it's like a dive. So it's like you almost like cup your hand and really dive in there and try to push down quite a bit. And then that's when you want to palpate the spleen, liver, kidneys, and McBurney's point. We'll talk about McBurney's point again in a minute. Rebound tenderness is a really good indication for an acute abdomen. So if this is, I wish this screen was, a little longer, but so if this is my stomach and I push down, the pain should get better when I take my hand off. Rebound tenderness is I push and pain gets worse when I release. Okay, that's more of a sign of a hot abdomen. Ooh. Okay, let me pause. Was there something else I wanted to say about that? I think we'll come back to it again in a little bit with the rest of the conditions. So nausea, vomiting, and diarrhea. Nausea and vomiting, we already talked about a little bit. When did pain enter the picture? Nausea and vomiting and diarrhea really can be treated most of the time with over-the-counters. We do have disintegrating Zofran, which works pretty well, but sometimes the taste of it can be enough to make you puke anyways. Important if the diarrhea could be infectious, meaning it's only been going on for a little bit of time. You do not, I repeat, you do not want to have your athletes take Imodium, okay? Because diarrhea is your body's response to either the pathogen or the toxin that the pathogen secretes. And so if you give them Imodium to stop your body from expelling that toxin, it's just going to build up there and they're going to get a lot sicker, okay? It's also important to know the character of the vomited material or stool. So sometimes people say a good example is like coffee ground emesis. Emesis is a fancy word for vomit. Coffee ground emesis, if it looks like that, like darkish color, that's actually because they're vomiting up congealed blood, because that's the color that blood turns when it hits the stomach acid. Okay, so that's a really important one to know. If it's more that like yellowish, greenish thing, probably bile and such as well, versus like, whole food. The Bristol stool chart, I didn't put it up here, probably should have, as a way to quantify what their stool looks like, because oftentimes most people struggle to describe. They're like, oh yeah, it was this or this or this, and it's this chart that somebody who needs a hobby created that ranks it from, really constipated to like really loose diarrhea, and there's pictures, okay? Symptoms that are present for more than 24 to 36 hours or accompanied by significant pain or fever, you need to refer out. The acute, like diarrhea and nausea, vomiting, typically lasts about 36 hours. Whoa. Okay, so viral gastroenteritis, that's quote unquote what people typically call the stomach flu. Okay, and remember back when we were talking about influenza and I said that it's not a flu at all, and that's one of my soapboxes, and here I use the term anyways. But when people say stomach flu, this is really what they have. Okay, so that's that self-limited inflammation of the stomach and intestines that usually completely resolves in 2 or 3 days. That's that I'm puking my guts out, I have so much diarrhea, I just feel like garbage, and I live on the bathroom floor. That's this one. People are contagious, often goes from food handlers, from people not washing their hands well enough, which is gross to tell a different story. One of the things you have to think about is dehydration and also electrolyte abnormalities. People who are having that much vomiting and that much diarrhea are going to leach their body of potassium as well as fluids. Okay, so poisoning or bacterial diarrhea, you start thinking about that when like your whole team gets sick at the same time. Because if it was truly like a viral thing, it would get one person, then a couple of days another person, and then a couple of days another person. It wouldn't be like everybody got sick overnight, okay? Because you have that incubation period. And like I said, sometimes the diarrhea is from the actual bacteria itself or the toxin that the bacteria releases. So parasitic infections, I think I've explained the concept of a zebra, but it's a lot more of a zebra in the States because we have treated water. People aren't drinking from streams and such, but this is when you need to, that history really matters. Like, has your patient been out of the country? Are they a backpacker and have they been like, drinking snow melt or from random streams? Do they live or had they been staying somewhere that's on well water, that kind of thing. Okay, so parasitic infections, particularly Giardia, is something that could also be a cause of diarrhea. I'm just going to pause for a minute because like stool patterns are something that people don't really want to talk about. They're pretty embarrassed about it. And so it's not uncommon for people to come to me to be like, yeah, I've had diarrhea for like 2 years and I just didn't say anything to anybody. It is not normal to have persistent diarrhea. And we'll talk about some more definitions coming up. But just as a disclaimer, if anybody like kind of offhands, like that's not normal, okay? So GI symptoms can 100% be stress induced or even anxiety induced. The mind-body connection is really, really strong. And so there can be a huge variety of symptoms, from diffuse abdominal pains and cramping to heartburn, nausea, vomiting, diarrhea, constipation. And it's important that this is a diagnosis of exclusion. And what that means is that in order to say that your diarrhea or that your heartburn is because of stress, I need to be able to prove that it's not anything else, meaning you need to have a colonoscopy, probably an upper endoscopy as well. You'll find, unfortunately, some providers are really quick when they don't either want to work it up or they're just jaded or what, I don't really know why, for some probably stupid reason. They're just like, oh, it's just stress. Oh, you're an athlete, you have too much on your plate. You're just stressed. You find that a lot. Women, the research shows women's symptoms get dismissed a lot more often than men because it's claimed that they're just, being dramatic or being a whiner. But truly, stress-induced GI symptoms is a diagnosis of exclusion, and we cannot accept it as a diagnosis unless we can prove that it's none of the other causes. So gastroesophageal reflux disease, heartburn, esophageal reflux, gastroesophageal reflux disease are all interchangeable. As I'm sure you're aware, medicine has so many what I call like $40 words, like I can't charge you $40 to say you have heartburn versus I can be like, oh, you have gastroesophageal reflux disease. Sounds a lot smarter, but really our job in medicine is to take what's technical and make it simple so that our patients can understand. So heartburn is a lot easier to understand. So what's happening is that stomach acid travels up through the lower esophageal sphincter into the esophagus, or sometimes even into the back of the throat. Like we talked about in respiratory, GERD is a super common cause of chronic cough, okay? Or even like hoarseness. It can affect people's vocal cords if the acid is traveling that far, okay? And GERD can affect athletes of any age, okay? And these symptoms are pretty common, even like 14% of adults. PPIs and other like antacids are available over the counters. I'm talking about like Prilosec or Protonix, not Tums, but which is also over the counter. But PPIs like the Prilosec, they're really only supposed to be used for like a couple months. Okay, you have people that are on them for years and years and years, which has a lot of risk with it too. They're not a benign medicine. Like I said, over the counter does not equal safe. Okay, so PPIs really should only be used for a short amount of time, typically like 8 weeks, and then we try to wean you off of it. And it's important too that people wean off of these medicines because PPI stands for proton pump inhibitor. And if you think about what we've talked about receptors, if this medicine is inhibiting that proton pump, okay, and the proton pump is the H+, which is the acid, which is making the stomach more acidic. So it's inhibiting the stomach's ability to make the stomach more acidic. So your body's natural adaptation to that is to create more receptors, right? Because it's like, whoa, 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 I have all of this molecule that can't bind to anything because the PPI is inhibiting it. Right? So all of a sudden your body goes from, just for example, say 10 receptors to 20 receptors because it's like, no, I have this molecule, it's not binding, I'm not getting the acid in there, okay? And so if you just stop your PPI right away, you then have 20 receptors that can throw that acid into your stomach. And then people are like, oh, no, I didn't tolerate coming off of it. When really it's you just didn't do it correctly and you didn't give your body the chance to down-regulate those receptors. So when we slowly wean off, it gives your body the chance to be like, oh, I didn't need that one. I have enough to down-regulate back to normal. Gastritis and peptic ulcer disease. So itis at the end of anything just means inflammation. So this is inflammation of the lining of the stomach. Peptic ulcer disease is one that gets a little bit more serious, in which there's a deeper ulceration in the stomach or in the duodenum. This is when that question is, your stomach pain improved or worsened by eating? If it's improved by eating, it's typically a duodenal ulcer. If it's worsened by eating, it's a stomach ulcer. In athletes, it's often too many NSAIDs, too much ibuprofen, and particularly on an empty stomach, too much alcohol. Or H. pylori is a bacterium that the end of its anatomy, it has this little hooky-like thing, and it hooks itself into your stomach lining and then just kind of erodes it there. So some of the testing that we can do is test for H. pylori and then give people antibiotics. But oftentimes in the younger populations, it's too much ibuprofen and too much alcohol. Irritable bowel syndrome is once again a diagnosis of exclusion, and remember what that means. That means I have to prove it's not anything else, okay? So IBS can present as diarrhea or constipation, or a mix of diarrhea and constipation. Peak prevalence is 20s and 30s, okay? It's defined as that abdominal discomfort or pain associated with altered bowel habits, i.e. diarrhea or constipation, for at least 3 days per month in the previous 3 months. So it's not even necessarily, that you have to have diarrhea every day. But I mean, even if you just have diarrhea 3 times per month for 3 months, that's not normal, okay? IBS is more common in women, is familial, and is often triggered by stress, like everything else in life. Inflammatory bowel disease, alternatively, is like Crohn's or ulcerative colitis, and that's really when we do that colonoscopy for diarrhea. That's one of the big things we're trying to rule out. Okay, because it's a pretty severe inflammatory disease that, you know, can, if it's not caught, people can end up having to have like total colectomies and such, and it can be, it's a pretty life-altering disease. The Crohn's has more disease in the small intestine, or ulcerative colitis can be like the whole intestine, and sometimes even outside the GI tract. And an important tidbit is if your athlete has diarrhea that wakes them up at night, okay, that's a red flag for inflammatory bowel disease. Like IBS typically does not wake you up at night, okay? And then unexpected weight loss. This is a big, especially with diarrhea, with unexpected weight loss, is a big, big red flag. Celiac disease, it's an autoimmune disorder that's thought to be triggered by dietary gluten. Treatment is don't eat gluten or no contact with gluten. It's a chronic inflammation of the small intestinal mucosa, which leads to atrophy of small intestinal villi and subsequent malabsorption. So there's a lot of $40 words in there. Remember back to your intestinal anatomy. Small intestine has all these little tiny finger-like projections, right? Because then that increases the surface area for it to absorb stuff, right? So essentially what happens with celiac disease is that inflammation makes those villi kind of shrink and kind of like curl up, and so that there's not as much room, surface area, to absorb nutrients and water and such. The treatment is gluten-free. Like I said, it's important to note when the patient is undergoing testing, a lot of times they've already been like, especially with all the rage of gluten right now, they've already been like, oh, I stopped eating gluten and my symptoms got better. But in order for us to confirm that it is celiac disease, they need to be on gluten, okay? Which can be really hard because patients are like, I stopped eating gluten, I feel so much better, and now you're gonna make me do it. And it's like, yeah, oftentimes. Like I said, more common in women. Important to remind your patients gluten is hidden in a lot of different things, like a lot of makeup products, for instance, have gluten in it. And depending on how sensitive the patient is, even just exposure like in a lipstick or something could be enough to increase their symptoms. Ooh. Appendicitis. This is one of those examples of that hot abdomen. It's the most common cause for urgent abdominal surgery in the US. It's caused from that acute obstruction and inflammation of the appendix. We really don't know the function of the appendix or why it's even there. People seem to do okay when we take it out though, so we don't really know yet. Typically what happens is people have like generalized abdominal pain, and then within 12 to 18 hours, it typically like localizes down to that right lower quadrant, which is where McBurney's point is, and that's typically the point of maximal tenderness, is that McBurney's point. Okay, but not everybody reads the textbook, and so not everybody's appendix is in that right lower quadrant. So even if you have somebody with like that kind of fits this picture, and the hairs are standing up on the back of your head, and you're like, you know, I think it might be appendicitis, but their pain is in the wrong place, still refer them out. Okay, low-grade fevers, nausea, and vomiting as well. And that's where McBurney's point is located. I think that one's my favorite. I like the crumple. So cholecystitis versus cholelithiasis. Fancy words for gallbladder stones versus gallbladder inflammation. Okay, gallstones are pretty common. There's certain times in life that they're more common, like after pregnancy and such. More common in women. Symptoms are generally caused by that stone blocking the bile duct that drains the gallbladder, and so then people will have tenderness right in that right upper quadrant. Okay, and one thing that's called is Murphy's sign. So if this is my right upper quadrant, if I go and somebody has cholecystitis and I go and palpate on it, they're going to go like as soon as you touch it and have that deeper palpation, because they'll catch their breath and be like, and want to kick you and swear at you and such because it hurts so much. Okay, colorectal cancer, it's a pretty common cancer, increases incidence with age. Okay, If your patient is complaining of blood in their stool, this is a big one to think about. And this isn't in the slides, but maybe I should have put it in there, is like hemorrhoids. Okay, so hemorrhoids come from sitting too long or straining to have bowel movements. And one of the differences between, and oftentimes there's bleeding associated with hemorrhoids, okay? So hemorrhoid blood, and this is just for your information, I would still 100% refer out anytime there's blood in the stool, make it somebody else's problem. But just as an FYI, hemorrhoid blood is on the outside of stool, and you see it most of the time just with like wiping. True like GI bleeding is everywhere, okay? And versus hemorrhoid blood is just like a little bit, it's bright red. Another thing to keep in black stool is a sign of either taking iron pills or blood in the stool, okay? And anytime you question or if you're concerned, refer them out. So say they have a family member who got diagnosed with colorectal cancer in their 40s, that patient needs to start screening 10 years before that first degree relative. Okay. And this is a great example. Chadwick Boseman, Black Panther, he filmed those movies while he was battling colorectal cancer. So oftentimes we have in our minds what people with cancer look like, that, you know, they have no hair and they're really frail and cachectic and they just look like they're going to break any second and they just vomit everywhere. But they can look like this too, okay? That's why it's super important that we don't just blow people off and we don't just be like, oh, it's stress, or oh, like, I know people don't like to talk about their poop, but like it's still important. And this is partially why, because he was only in his early 40s when he passed. Okay, so super important that we keep an eye out for all of these different things, because we can really help make a difference for these patients.